Thank you, Steve. It's really a pleasure and honor to be presenting to such a august group and such a deep feeling group. And one of the things I'll tell you, there is an innate fear associated with infectious diseases. And that fear is actually, in some ways, protective, but it can get out of control. And one of the ways you can manage that fear is to deeply understand the actual the disease, its manifestations, how it spreads, and how you can actually help to prevent its spread. So that's what I'm going to cover in this presentation, and I look forward to answering a large number of questions. Oh, I need to be enabled to share my, whoever's the organizer has to allow me to share my desktop.
Yeah, we're working on that right now.
Okay, sorry. I should have checked that. That's a common issue.
Try again.
Yeah, that's good. That's good. Got it. So I'm going to try to, oh, actually, let me 1 second. I want to share that in a little different way because I have one video and I gotta, there's a certain way to share that makes sure you can hear it. There are two little checks. I got them now. Okay, good. So, I tried to frame this for everyone that's going to church, what you really need to know, and this knowledge will be very helpful as you make decisions, because as our discussion will reveal, there aren't right and wrong answers. There are various levels of risk and benefit. So the more you know about the risks of the virus, the more you can weigh the benefits of service of various activities during religious services. So what can happen? I want to start with what can happen when someone becomes infected with SARS-CoV-2. And I would point out that COVID-19 is the name of the disease caused by the virus SARS-CoV-2. So this is the case that I actually took care of. I've changed a few of the details, but this is a middle-aged woman who served as a respiratory therapist at a medical facility, not at UF Health. 6 days before her hospitalization, she was exposed to 3 COVID-19 positive patients while changing tracheostomy tubes. And it's well known that these tubes, when you change them, you produce an aerosol. And we'll talk more about that a little later. And she had gone to administration of their health system and asked for N95 masks, the mask that protects against aerosols. And they said they were out of them. So she had to wear a surgical mask, which is insufficient with this kind of procedure. 3 days later, she went to her diabetes clinic and was screened and found to have a fever and was turned away. And then 4 days after her exposure, she experienced fever, fatigue, chills, and a dry, hacking cough. And then 5 days after her exposure, she walked to the kitchen and became very short of breath with oxygen saturations because she had a pulse ox. She's a respiratory therapist. She checked her pulse oximetry and it was 83%. It should have been 96 to 100%. On the 6th day, she was admitted and noted to have a fever, 102.6 degrees Fahrenheit, and her oxygen saturation on room air was low at 88%. Her chest X-ray showed pneumonia and a polymerase chain reaction for COVID-19 or SARS-CoV-2 was positive. She was placed on 4 liters of oxygen, and on the second hospital day, her respiratory rate climbed up to 38, normal being about 16, and her oxygen saturation on a 100% rebreather mask was only 88%. And she was transferred to the intensive care unit, had to go under intubation and ventilatory support, was placed on 70% of oxygen. And even with that very high concentration of oxygen, her PO2 was only 74, If someone with normal lungs was received 70% oxygen, the PO2 would be about 400. She required proning to improve her oxygenation, that is lying on her stomach as she was intubated. And over time, her oxygenation did improve. But subsequently, she developed shock, kidney failure, and her lymphocyte count was very low. And on day 6, we gave her IV intravenous convalescent plasma from a patient who had been infected with COVID-19 and had recovered. 48 hours after that, she began to improve. And on day 17, she was extubated and now is undergoing rehabilitation for severe weakness, having needed to be paralyzed to maintain her ventilatory support with a ventilator. Here was her chest x-ray on the left. Day 1, you can see there's a lot of abnormal white areas, but then there's some clear areas. But by the second day, you can see that the lungs are pretty much white. And we call that white out of the lungs. And that is indicative, that is strong evidence for what we call acute respiratory distress syndrome, or ARDS. So she developed acute respiratory distress syndrome. She had blood pressures of 70 systolic. She had no urine output, and she very nearly died. And unfortunately, this is not a rare experience. And some people question whether there are cases like this. But if you ask any doctor or nurse in a large metropolitan area hospital, they will tell you many stories very similar to this. But this sort of, you want to know when you're thinking about screening and when you're thinking about your own self, whether you may be developing this infection, what are the prominent symptoms? And this is a series from New England Journal of 1,099 patients from China. And the bar graphs, the medium gray graph is all patients. The light gray bar is less severe patients, and the black bar is severe patients. So when it comes to a fever, 95% of all patients will develop fever. When it comes to cough, it's approximately 70 to 75% have a dry cough. And that doesn't matter what the severity is. And over time, they often will develop a little bit of sputum. They'll bring up some sputum over time, and that happens in about 30%. Shortness of breath is not as common, and in non-severe disease, it's only in about 15%. However, those with severe disease, it's approximately 40% develop shortness of breath. So shortness of breath is a very worrisome symptom. Another symptom that's very common is fatigue. People feel extremely tired. Myalgias or muscle aches. And more recently, it's been appreciated a modest number have headaches. Nausea and vomiting may occur. Diarrhea and abdominal pain are relatively rare. And a very specific symptom is loss of smell and taste. And this seems to be unique to the COVID-19 infection. Now, who is at higher risk for developing severe disease and potentially dying? The overall mortality is 0.5 to 3.5%. Influenza, for comparison, is 0.1% mortality. So this infection has a 5 to 35 times higher mortality than influenza. And some people have claimed that it was equal to influenza. It is not. It is far more serious. If you have underlying disease, you have a higher risk of mortality. And those with diabetes have a 7.3% on average. Hypertension, the mortality goes up to 6. Cardiovascular disease, 10.5. Chronic lung disease, 6.3. Obesity is definitely associated with increased severity. The exact increase in case fatality has not been reported yet. And individuals with cancer have a higher case fatality rate. I would point out, and we talked about Bishop Carter talked about the problem of African Americans and the discrimination they're undergoing. Unfortunately, because they have not gotten the care they need in our health systems, they have much higher incidences of diabetes, hypertension, cardiovascular disease, and obesity. And a higher number of African Americans have died than, based on the percentage, a far higher percent have died than other races. Now, the other major risk factor is age. Those under 30 almost never have a fatal case. It's exceedingly rare, and they usually have an underlying disease. But as you get up to age 50 to 59, you have about a 2% mortality, 60 to 69, a 4% mortality, and 70 to 79, an 8% risk of death. And those over 80, it's anywhere from 15 to 25% increased likelihood of dying. So to summarize this part of my talk on the manifestations and outcome, fever, dry cough, and shortness of breath are the major symptoms. Fatigue, muscle aches, headache, diarrhea, abdominal pain, and loss of smell and taste. And the major problem is decreased oxygenation of the blood, or hypoxia, and leading due to ARDS, or acute respiratory distress syndrome, and also can be accompanied, when even more severe, shock and organ failure. The case fatality rate is 0.5 to 3.5%, 5 to 35 times higher than influenza. And patients with diabetes, hypertension, cardiovascular disease, chronic obstructive pulmonary disease, cancer, and obesity have a higher mortality rate. And there is age is a key risk factor, and those over 80 have a 15 to 25% mortality. Now, what is causing this deadly disease? I think it's important to understand a little bit about the virus. It's in the coronavirus family, and there are hundreds of coronaviruses that infect the entire animal kingdom. When it comes to humans, there are 7 strains. And before 2004, there were 4 strains, and they were all of low pathogenicity, that is, they caused mild disease. They caused a simple viral URI or cold, just like rhinovirus. You can't differentiate them clinically. However, in 2004, out of China, a live animal market, came SARS, now called SARS-CoV-1. And that virus presented very similar to SARS-CoV-2 and was associated with ARDS and had a mortality of approximately 15%. It got up to approximately 8,000 cases, but then due to infection control, it was controlled, and this virus is no longer circulating. In 2013, MERS-CoV was first recognized, and that's in the Middle East, and that's the Middle Eastern Respiratory Syndrome. And it is continuing to spread, but it's at very low levels, approximately 1,000 patients, but it has a mortality of 30 to 33%. And then in 2019, probably in December or late November, SARS-CoV-2 came on the horizon, and that's the virus we're talking about today. Now, the World Health Organization picked COVID-19 to describe the infection, and SARS-CoV-2 to eliminate any geography or any race or any other characteristic that might lead to racism and blame, which are very common behaviors in the setting of an epidemic, is to blame others for what's happened. Now, there's been a lot of questions about where this came from. And it's SARS-CoV-2 is 96.2% identical to a bat virus called RATG13. And there's no question that it came from the bat. And it turns out that when coronaviruses grow in bats, they have a tendency to mutate more frequently, possibly because of the body temperature. It's not really known, but we do know that more mutations take place. And what happened, there was a mutation in a bat virus, very probably this RATG13, that created the SARS-CoV-2. And the mutations were in an S protein and the NOB protein, rendering them more able to infect human cells. And the bat virus spread to an intermediate mammalian host thought to be the pangolin, which is an anteater-like animal that is prized by the Chinese and sold in live Chinese markets. So the virus is called corona for crown because the little knobs or S protein, these red parts appear like a crown. And these surface knobs are responsible are bind to specific human cells. And in the case of this virus, bind the ACE2 receptor on respiratory lining cells or bronchial epithelial cells. And they bind with much higher affinity than for SARS, explaining the very high infectiousness of this virus. So I'll go into a little bit more detail. I'm a cell biologist, so I just want to show you how it actually spreads. It binds to these two receptors, and then once it binds, it's ingested, or what we call endocytosis. It's actually brought into the cytoplasm of the cell, and there the RNA actually serves as a template to synthesize a protein replicase, and that replicase causes the replication of the RNA, the reproduction of RNA strands. So there are multiple strands of the viral RNA produced within the cytoplasm of the cell, and then they form into nuclear capsids. At the same time, another RNA signals transcription or protein synthesis of the S protein and several other surface proteins, and those are actually synthesized or assembled in the endoplasmic reticulum. The nuclear capsid butts the endoplasmic reticulum and is surrounded by it and coats the outer surface with these proteins. And then the virus is stored in a vesicle, a little vacuole, and then is pushed out or exocytosed over time and released, and then it binds to other cells and also enters the sputum and saliva. So once the virus is out and is spread from one person to another, it enters the upper airways. And here for the first 24 to 48 hours, it replicates very rapidly. And during this period, many people have very few symptoms, maybe a little bit of a runny nose, but many have no symptoms during this period of time. And then after 48 hours, it moves into the lower respiratory tract, the bronchi, and then into the alveoli. And the alveoli are little air sacs responsible for exchanging oxygen in the arterioles, and explains how we get oxygen into our blood. With ongoing inflammation due to the infection, there is an exudate, a fluid that leaks into the alveoli and then blocks oxygen exchange, and the alveoli no longer function, and the arteries cannot take up oxygen. And that explains the predominant symptom and predominant problem with this disease, which is hypoxia or low oxygen levels in the blood. So the next question is, how does the virus spread? Well, and this is very important when we're thinking about worship. I think everybody agrees now that it's predominantly by droplets. It turns out when we speak, we actually produce droplets. These droplets are fairly large, and they will drop to the ground in about approximately 1.5 meters to 2 meters, or under 6 feet. And coughing usually will only project that far. Speaking will be a little bit shorter. A sneeze actually can go beyond 6 feet, and that's why now masks are being recommended even when you distance yourself. Now, these droplets also fall to the ground, and there was a very serious concern early on that the contaminated surfaces would be another way that it was spread. However, the epidemiology appears that this is a very rare way to spread. Early on, everybody was emphasizing that this virus could stay alive on stainless steel and plastic for up to 3 days. And so cleaning, rigorous cleaning had been a very big concern, and people were cleaning their groceries. It's become very clear now that that kind of excessive cleaning is not necessary, but hand washing is important, and periodically cleaning surfaces is important. I would point out that if you leave a surface for 3 days, if you don't use an area for 3 days, it will naturally decontaminate itself. Now, another key point is that certain activities create aerosols. These are droplets that are less than 10 microns. Now, why is that important? Because these small particles form a gas and stay up in the air, and they can stay in the air for up to 3 hours. So if someone were to walk over to a place where someone had produced that aerosol and they breathed it in, the other worrisome thing is this aerosol is so small, it doesn't get stuck in the upper airway passage. It will go right down into the alveoli and the infection will take off. Now, it turns out, unfortunately, singing is well known to cause aerosols. The other big problem is that 40 to 60% of those that are infected do not have symptoms when they are tested. Now, early on, when you first get that upper airway, you may not have symptoms, so you could be pre-symptomatic. Some individuals have the infection the entire time and do not have symptoms. So the point to keep in mind is that you could have the infection and not know it and spread it to others. Now, other ways theoretically could be spread by stool, there is PCR positive for stool, but there have been no transmission by that route. And perinatally, pregnant women theoretically could spread it to their fetus. That is proven not to be the case. Now, another big concern is the problem of superspreaders. There are certain individuals that seem to be highly infectious. And there's one case 31 from South Korea. This woman who is 36 years old, she traveled from Hunan, China to South Korea and attended a mega church twice, also went to a hospital after she got a small car accident, and also attended a buffet at a time that she did develop fever. Early on, she did not have symptoms, and the epidemiology contact tracing reveals that she exposed 1,160 contacts and was responsible for a common source outbreak that actually got up to about 4,000 cases. So large gatherings can be very dangerous. Now, what is the efficiency of transmission? Now, and on average, one individual that is infected will infect 2 to 2.7 individuals. And this is called the R sub 0. So the R sub 0 is 2 to 2.7. 10% of close contacts will develop the disease, and 80 to 85% of those that contract the disease are within families. So someone can pick it up outside, then come into the family and spread it into the family. Now, if you look at the initial outbreak, it was in the Hunan live animal market, and the orange shows the workers in that market. And early on, the predominant cases were in those that worked in the market. However, there were some that had never been in the market. Within 10 days, look at the percentage infected that were not in the market. And finally, 20 days, virtually no cases from the market. They were all from outside. This indicated very early on that there was very rapid person-to-person spread. And what happened is it started off in Hunan, it spread through the whole province, then it spread throughout a large province in that area, and spread the whole east coast of China. And these are 10-day intervals. That's how fast it moved. Each 10 days, it was spreading very, very rapidly. And then it has spread to the United States. And this is 4 days ago, showing that there are now 7 million cases and 404,000 deaths. After China, it spread probably in Italy, where there was a fashion show, and China is responsible for manufacturing a large number of clothes. And from there, we think it's quite clear, actually, from the sequencing, that tourists from the United States who are visiting northern Italy then brought it to New York City. Also, from China to Seattle was a major route. And Seattle actually was the first place with a large outbreak. Now, I'm showing you, this is a picture. Some of you saw the editorial in the Gainesville Sun. I had Bruno Lucchesi, a very famous artist, draw me a picture of the Pandora's jar, sometimes called Pandora's box. And Zeus actually created this Pandora's jar and created Pandora, a beautiful maiden who he knew would be curious and open the jar. And in that jar, he created he put all the pests of the world. And he warned that when that jar opened, there would be the spread of pestilence throughout the world. That was 3,000 years ago, and now Pandora's jar has been opened, leading to death and suffering. Now, when a government decides not to intervene aggressively with infection control methods, that is the equivalent of leaving Pandora's jar open. And when they don't respond to new findings and do not attempt to close the jar, then suffering and death will ensue. Now, this exemplifies what I'm talking about. This is a graph from, this was in April 25th, which is really when the major part of the epidemic began to spread. And this is the number of deaths on the vertical axis, and that is log. So that's 1,000, 2,000, 500, 200, 100. And this is time after there have been 3 deaths in a country in days. The stars indicate when a lockdown or shelter in place was implemented in the individual countries. And I want to show South Korea, the light blue. They intervened, they're the first star here. They intervened after only, there were an average of 3 deaths per day, and they had approximately 30 deaths. They began lockdown, infection control, and contact tracing and isolation. The next star is China. And China also intervened after 30 deaths and 3 deaths per day. And here is the orange. They're a much larger population. Initially it was steep, but as you can see, China has dropped down to very few deaths per day. They have had one other small wave since then. And then a look at this star. This is Italy in black. Italy chose to intervene when there were 75 deaths per day and after 800 deaths. And as a consequence of this, Italy, of all the European countries, has suffered the most deaths of any country, and their health system was devastated. Look at the US is in red. There are no stars involved with the US because some states chose not to shelter in place, and different states started at different times. The duration of their shelter in place have been relatively very short. As a consequence, we have not derived huge benefits. We have benefited some, and that explains the very steep curve. And the US, as of April, was experiencing 2,000 deaths per day. I think we're down to about 800 to 1,000 deaths per day. But we, as a consequence of our failure to actually close Pandora's jar, the United States leads the world in deaths by 3 to 4-fold and by cases by 3 to 4-fold. And here, as of June 8th, these are the actual number of cases. New York is the highest at 207,000. Chicago is second at 82,000, followed by Los Angeles, Detroit, Miami, New Orleans, and finally Seattle at 8,400. The place where there were the highest number of cases is now one of the cities with the lowest number as a consequence of aggressive infection control. Now here, I just wanted to show you what happened early on in Florida. You can see this is March 9th. There were only a very few cases, and they were all along the West Coast and 1 case out in the Panhandle. The following day, there were a few more cases. The following day, more cases. And now there were some developing on the East Coast and several in Daytona Beach area, and 1 case in Gainesville. And then the 12th, more cases were developing, and it continued to progress along the West Coast, but more and more cases on the East Coast, in particular the Daytona and Miami area became very heavy as far as cases. And at that time, as of 3/16, this is the number of cases each day, and it was an exponential curve with a doubling time of the cases were doubling every 1.8 days at that point. Now, since then, shelter in place has been and was implemented on approximately April 6th, and in Alachua County, it was actually a little bit earlier. We actually really started aggressively isolating in mid-March. And you can see the doubling time in Florida, instead of 427 was 12 days, and the doubling time in Alachua County was 14.5 days. Alachua County is still very delayed doubling time, and Florida is still maintaining a lower doubling time, but the number of cases seems to be increasing the last several days. So to summarize this part of the talk, transmission is by droplets, less commonly by fomites. Be aware of super spreaders. Droplets can travel up to 6 feet, and sneezes farther, and masks will be helpful for everyone. And it began as a common source outbreak in a live animal fish market in Hunan, China, as a consequence of a bat virus that had mutated so it could infect humans. Worldwide cases have increased from 1.4 million in April 9th to over 7 million. And rapid intervention has been the key to reducing cases. Unfortunately, many countries were delayed. And the US, because of its delays in intervention, has suffered approximately 2 million cases and 110,000 deaths. Now, how about the diagnosis and prevention? So the way we actually diagnose this is by polymerase chain reaction, where they actually produce the RNA is synthesized to DNA, and you keep synthesizing the DNA. And by the number of cycles, you can determine the number of viral particles from this. And the lower the number of cycles to get to detectable rate, the higher the viral concentration. This is a highly specific test, and it's highly sensitive. It will pick up 10 virions. The problem has been sampling. You can sample the nose once, and the sensitivity is 70 to 80%. That is, you're going to miss 20 to 30%. And if you do a second sample, you will pick it up. So it's a sampling issue. So the point being that a positive test is definitely positive. You have the infection. If you have a negative, you have a 20 to 30% chance it's a false negative. And therefore, if someone really has symptoms classic for COVID-19, it is recommended that that test be repeated. Now, the other thing you've heard about is antibody testing. And we do have some good antibody tests. Abbott has a very highly specific and sensitive test, as does Roche. And these tests will detect antibodies directed against the virus, and specifically against the S protein, the NOB protein. The problem is, here is the vertical axis is antibody concentration, and the horizontal axis is days after onset of that infection. And you can see for the first 7 to 9 days, there's virtually no antibody. At 10 to 14 days, virtually everyone begins to produce antibodies. And then it is quite sensitive and quite specific after that time point. But the problem is, you need to diagnose before this. Therefore, antibodies are not helpful for diagnosis. They're helpful epidemiologically to determine the number of cases in your area, and epidemiologists are using it. The question of whether, if you have antibody, are you protected from getting infection? It's highly possible, but not proven. And the test will not, at this point, be used in that way. There were many inaccurate tests on the market. Many of them have been cleared away, but there still may be some. But I think most labs know which tests are highly sensitive and specific. Now, everybody says, well, what about a vaccine? Isn't it going to come by October? I think that is highly, highly unlikely. And my estimate, and I'm not a vaccine expert, but I have seen vaccines develop. We are faster, more efficient than we were, but I think the minimum is 12 months and far more likely 18 months before we have a vaccine. So we cannot count on that. Therefore, we have to go to what we call non-pharmacologic methods of prevention. And those are, and the Imperial College, I think, is the most brilliant and clear at describing what those are. Isolation. All infected, when we do the test and we find somebody's positive, they have to be isolated. They have to avoid contact with others, wear masks, and stay a distance of over 6 feet. And those that come in contact with them, and the definition is within 6 feet for over 15 minutes, they need to be quarantined. That is, they have to avoid contact with others for 14 days. And if they develop symptoms, they will need to be tested and to prove whether or not they have the infection. Social distancing. One method is just to distance those that are over age 70 that have the highest risk. Tactic 4 is to social distance the entire population. And finally, the fifth tactic is to close schools and universities. Now, there are two approaches to controlling an epidemic. Suppression, that is using all 5 of those methods. And that way you can get the R sub 0 to less than 1. The other approach is mitigation. That is, you use isolation, quarantining, and social distancing, however, and not closing the schools and businesses, and that will not reduce the R sub 0 below 1. It will stay above 1. And they actually modeled the 3 interventions. 1, what if you do nothing? And this is the upper is the lower scale, and this is the lower graph is just a magnification of the base of this graph. And you can see that, and the red line is the number of ICU beds in a hospital system. And you can see if there was no intervention, the number of cases would exceed the capacity of the healthcare system by about 50-fold. So it would be absolutely a disaster. And it was estimated that Great Britain would suffer 520,000 deaths, and the United States somewhere from 1.2 to 2.4 million deaths if there was no intervention. If you use mitigation, the orange line, you will stay below the capacity of the health system temporarily, but will rise above it over time and then go very high. If you use suppression, which actually we did do for a period of time with closing all businesses and shelter in place, you will get a very low peak and never exceed the capacity of the ICU beds. Now, what was recommended in the Imperial College was 3 months of shelter in place, and most states only held out a month because of political pressure and pressure from the business world. So what they knew is even if you went 3 months, there will be second, third, fourth, fifth waves. And the question was how to decide when to intervene again. And one of the models was if a certain number of ICU beds became filled with COVID-19 patients, that would trip a new shelter in place. You can see over time that the area under the curve does decrease and the epidemic does finally fade. Now, ICU beds is a very delayed, that will take from the time of exposure of all these people, approximately 4 weeks for the signal to develop before you would intervene. And there is a much better way, I believe, of actually detecting a new wave, and that is an electronic thermometer that actually is very quick at reading put it under your tongue, it reads your temperature within 2 seconds, and then it feeds a signal by Bluetooth to your smartphone, which then transmits that to a central data bank. And this data bank looks at the region where you are, and then the average number of fever expected, and if you're higher than, if the fever curve in that area for a large population is higher, that's indicative of a new influenza-like illness. And this was for influenza. This was published in Clinical Infectious Disease, and you can see there was a peak. This is the number of visits for an influenza-like illness, and you can see there was a peak here, and at the same time, the number of individuals with fever peaked at the same in the same pattern. And the actual correlation between visits to the hospital and this temperature thermal map was a 0.95, a 95% accuracy. So the thing about this signal occurred 3 weeks before people started coming to the hospital. So here actually is a fever map, a weather map of Florida yesterday. And this is showing a modest increase in fever activity in the Panhandle, in this corner here near Tallahassee, and the entire west coast of Florida, warning that we are beginning, and also the Miami area, warning that we may be getting a new onset of COVID-19. Now, what are the trends as far as the R sub 0? In New York, when there was a start back here, this was an R sub 0 of 5 before they intervened. Now, after their shelter in place, they are down to 0.8. Michigan had an R sub 0 of 3. They're down to 0.8. Florida, we were at 3. We are now at 1.2. So we have not brought our R sub 0 below 1. And I would point out, look at Texas. Texas is the highest. Its R sub 0 is 1.6, 1.7. And Arizona is high. Illinois is high. Colorado is high. Ohio, Minnesota, Indiana, Iowa, Alabama, Wisconsin, Mississippi, Tennessee all have R sub 0s above 1. That means the epidemic is continuing to spread. And here is just a graph of the R sub 0. And here, when we started shelter in place, the R sub 0 dropped down dramatically. We actually started in April 6th, but a lot of people, that's when the businesses were all closed. But actually, a lot of people were sheltering in place before that. And you can see here, April 15th, we got down to an R sub 0 of approximately 0.6, 0.8. However, once shelter in place was ended, you can see that the R sub 0 has gone up, and now it is 1.2. Now, what's going to happen? What's the prediction? Well, the Imperial College has looked at the increase in mobility, and mobility equals, as your mobility increases, it's predicted the R sub 0 will increase. If mobility is unchanged, we stay where we were in shelter in place predominantly, we will only experience 10 to 20 deaths per day at a maximum, what we are now. However, if we increase 20%, we will experience, as of July 6th, this is the prediction, and this is the most pessimistic prediction, we could experience 300 deaths per day. And if we were to mobilize up to 40%, it is estimated that we could have up to 1,000 deaths per day. So they pointed out in their description that they were not taking into account use of face masks. So what could happen to the R sub 0 if we use face masks? And there is now a study out, just came out yesterday, simulating this, pointing out that if we could use face masks, we could, and 80% of individuals use them, we could drop the R sub 0 to less than 1. Now, I want to show a little video of a letter where that showed a laser light scattering measurement of droplets. And here you'll see someone talking at different levels, and then they will put on a mask. So here it goes.
Stay healthy.
Great,
Stay healthy.
great. Less loud.
Stay healthy.
Do it.
Are you recording?
Yeah.
Stay healthy.
Louder.
Stay healthy.
Louder.
Stay healthy.
Nothing.
So you see that face masks are very, very effective at eliminating droplets from spreading when you talk. Now, I have Kathy wearing a face shield because there is quite good evidence that in addition to face masks, face shields could serve the same purpose. They are more comfortable, they are reusable, and you can actually see someone's face and their expressions. And I predict over the ensuing months that this will become another method for reducing droplets. So what are some other preventive measures that I think will be needed for church services? I think it will be important to screen all participants. And I think syndromic and epidemiologic questions, have they been exposed? Have they traveled to an endemic area? Do they have fever? Do they have cough? Do they have sore throat? And checking their temperature at the door is somewhat effective, but actually, ideally, it'd be nice to check your temperature twice a day. And then who should be tested? This is difficult and is, I think, a moving target. Certainly those that are symptomatic and those who have been exposed to someone that's proven to have COVID-19. When else to be using that is debatable, and we can talk about that in the question and answer period. But one group that I think should be tested, if you want someone to be singing, they have to be proven not to have the infection. And I think that the PCR should be considered in that circumstance. Gatherings should be small as possible. I think this juncture, 50 to 100 maximum. Remember that in average in Florida, it's 2% of individuals are probably infected, although we don't really know that. So that means that 1 in 50 individuals on average might be infected and might not have symptoms. So the larger the gathering, the higher the risk that there's someone that might transmit the virus. Distance is 6 feet, high ceiling rooms, and larger or better. Ventilation, bringing air from outside, 3 volumes per hour or higher is ideal. Plastic barriers, if there are areas where there's going to be frequent face-to-face interactions. And whenever possible, be outside. The outside is very safe because the droplets are quickly diluted by the breezes, and there are very few, exceedingly few cases documented that have been spread outside. Now, with the demonstrations that have occurred, that rule may have been changed, but in general, that's the case. And finally, I wanted to talk about a zone approach. That is, knowing the prevalence of infection in your area. So there are 3 zones that are thought to be important. Red, if there's over 100 cases per 100,000, that suggests a high risk. And you can see the areas in the Northeast and some other areas are red. Orange means that there are less than 1% or below 100 per 100,000. You can see that most of the country actually is in this yellow or orange zone. Green is less than 1 per 60,000 or 1.7 per 100,000. And there are some zones, they're very rural areas, but this is not broken down into individual counties, which is another thing that can be done by the churches. So to summarize the last part of my talk, PCR is the test of choice for determining whether or not when someone is actively infected, antibody levels indicate past infection and may indicate protection. Vaccine is probably 18 months away, so we're going to need to use non-pharmacologic methods, shelter at home, reduce the R sub 0 to less than 1 in Florida temporarily, but with increased movement is going to come increased R sub 0, and now ours is 1.2 and rising on the West Coast. Screening with temperature and syndrome inquiry is helpful. Masks or face shields for everyone in public, closed spaces has the potential to drop the R sub 0 below 1. Distancing at 6 feet, staying in large, high ceiling spaces with good ventilation, and stay outdoors whenever possible. So thank you. Let me end here, and we can entertain questions.
Thank you so much, Dr. Southwick. We really appreciate this incredible information you've shared with us. I'm going to read some questions, and we'll try to get to as many as we can. And the first question is, do you advise greeters to use infrared thermometer scanners in order to screen worshipers before entering the worship space? And if so, what would be an unacceptable reading for admittance?
This is debatable. How effective that screen is, it's somewhat questionable. I think employers are doing that. Whether churches need to do that, I don't think so. The rule of thumb is 100.4 or 38 degrees Fahrenheit or 38 degrees centigrade. I think it's going to be hard for churches to do and to ask syndromic questions. I think it's probably going to be self-policing and the parishioners checking their temperatures at home and making sure they don't have a fever probably will be the best. Now, if you have a very small gathering and you're really concerned, those things may catch some people. In fact, the case that I described went to diabetes clinic and was caught using that scanning system. And I can tell you UF Health, when anybody enters the buildings, they are doing that screening. So I think it's variable. And the other thing I would say, maybe if you're in a red zone, it might make more sense. If you're in a yellow, most of us are in yellow. In green, you probably don't need to do it.
Thank you. Some people are asking about singing. If they had a couple singers at the front, some soloists, what is your recommendation on a few soloists singing?
A number of 506 epidemiologists were polled on singing, and all of them are opposed to it virtually, because the aerosol, remember, it's an aerosol that can float in the air. It can just float away. Unfortunately, plastic blockages, even face shields and masks, will not protect aerosols. They will float around those masks. And in the case that I had described, she was wearing a surgical mask and got a very severe, infection that almost killed her. There's an article in the New York Times I will give to Steve yesterday that pointed out that there have been severe common source outbreaks from choir practices all over the world. And that this is just one of the major ways you could create a large outbreak very, very quickly. And then that could spread theoretically because the symptoms won't develop for several days. Meanwhile, all those people will be coming in contact. You could create a giant outbreak in your community as a consequence of singing. So I think it's too dangerous. The only way I can see doing it is assuring that those who are singing are not infected. And talking to epidemiologists, if you did a COVID PCR every 2 weeks, that would be pretty syndromic, and had them kept their temperatures, that would assure that those who are singing are not infected. But I think that's the only safe way I can think of, unfortunately.
Thank you. Someone asked if they're outside and 8 feet apart outside, is it safe to sing, and do they need to wear masks outside?
I don't think if you're 8 feet away, you do not need masks. And actually, masks aren't going to help with singing anyway because it's aerosol. I think if there's a gentle breeze, you're okay. If it was absolutely stagnant, it's possible even then that might be a little dangerous. But I think it's certainly a lot safer outside. But the other thing, I don't know if any of you watched American Idol, how they were able to bring in virtually multiple singers to create harmony virtually. And I think there are technologies that would allow individuals to harmonize virtually. And I think it might be worth exploring that methodology at this point. The other thing could be you could record the songs ahead of time and show videos of the people singing, or they could lip sync. Those are the other two alternatives.
Thank you. Someone asked about cleaning. Do they need to do a deep sanitizing of their church? It was going to cost about $4,000. What's your recommendation?
No, I don't think that's necessary. Originally, we would have said yes. No, unless the only place they need that kind of deep cleaning is very high utilization areas like subways, mass transit. Otherwise, it makes no sense. And lots of times in churches, you might, the large worship service, you will have them one day and then you have 7 days before the next one. The virus will be dead. The beauty is time, 3 days, and all the virus will be dead. This virus is very sensitive to time and conditions and UV light. And so and so far there have been very few cases that have spread from hand to mouth or face. So I think that was a big worry early on, but it's becoming less and less. And I would not expend $4,000 on a deep cleaning.
Okay. One person asked about getting county by county statistics and using that. And I would just say, I know they can get that on the Florida Department of Health website. There's also a COVID Act Now website that could be helpful. Is there anything you want to say about a county by county approach in terms of trying to decide whether to open your church again?
I think it makes sense. And the one problem is, the accuracy of these values. It depends on how much testing is being done in your area. Different public health departments, local ones, have a more aggressive testing. For instance, because of University of Florida, we have very high percentage testing, and it's very available. In other areas, it might not, and therefore it would look fine when it really wasn't. So I think you can use that to be somewhat helpful, decide whether you're a red, yellow, or green zone, but be a little cautious about it. It's not foolproof.
One person asked, how might the virus mutate? Is there any?
It turns out the good news is it's minimal mutation. That is not going to be a concern. The vaccine will, if we get a vaccine, the virus won't mutate so that the vaccine is not effective. There are several strains, but they're really small changes that are helpful for determining how the virus spread, but are not, as far as anybody can tell, do not affect its aggressiveness or its virulence at all.
Great. One person wanted you to comment on a test that UF has developed, as well as a rapid COVID test. Do you see any of that being developed?
Well, there are antigen tests that are being developed, and if you could get an antigen test, like a rapid strep test is an antigen test, that would be terrific. The specificity of this is very, very tricky. And there is one release now, but their specificity and sensitivity is not known. The worst thing you could do is if you have a test that had a high false positive rate. Oh my goodness, then everybody would be isolated unnecessarily, and a high false negative rate. If you miss a number, then they'll think they're okay. So I think at this point, that's not in the immediate horizon, maybe in about 2 or 3 months. And that could be a bedside test. That is, it could be a point of care test. It could take less than 30 minutes to do, which would be ideal if we could get that. But it's still not ready yet. But that's a hope, and that would make life a lot easier.
Okay, one person wanted to know, should they wait until they see 2 straight weeks of declining numbers before reopening their church?
That is the ideal, if you can do that. It's really hard to know. I think with all the descriptions of the infection control approaches that I described, and the churches, these are not, the church has already gone through all these. This is just to reemphasize. I agree with their plans. I think unless you're a really hot red, I think you're probably okay to go ahead. Okay.
And some have said that, like the counties where they are, the cases are lower, which they think they could open up faster. And you're saying that that could be the case. But again, as
yes,
you said,
I think that's, yes. I mean, one of the issues is the size of your gatherings. And,
right.
and I would, we, Steve and Catherine and I talked, the whole committee talked yesterday. And I think the best approach is start off small. See if you got the logistics down for making sure, because you're going to have to keep people far apart and make sure people don't start talking, make sure they're wearing their masks, etc. Start small and then build up. Now, what the maximum size you have, I think that will be highly dependent on the prevalence in your area. In other words, the number of cases per 100,000. I would keep it, if you're a higher level, you better keep it smaller. If it's a lower level, you might go a little larger.
Okay. Talk about air conditioning. How does that impact the virus spread as people worship? Should they have the fan on and or the air conditioning with the fan?
The key really is ventilation from outside. Inside ventilation is not a particularly good, and might be dangerous, in that you would just swirl around the air droplets and aerosol. Air conditioning itself has not been shown to infect anyone. And usually the filtration systems in air conditioning are sufficient. They would remove most of the droplets. So I think I wouldn't, if you're air conditioning, if you're sucking the air from outside, turn it up. If it's inside, I wouldn't.
Okay. What do you recommend people do if someone refuses to wear a mask?
I really don't think they should attend service.
Okay.
I mean, Well, I heard a great quote yesterday. It was in this article about how important masks are. My mask protects you. Your mask protects me. So the individual that says they don't want to wear a mask says, I don't care about you. Now, that doesn't smell very good when it comes to religious services and coming together. We are a community that cares about each other. And if an individual does not care about the community, should they really be there?
Very helpful. Thank you. Any tips on how they can interpret the data for their congregation in an ongoing way? What would be the data points you would recommend they focus on?
Well, I think if someone tests positive, you really want to know that. And I would say one case is worrisome because our experience is for every one case that's detected, there are at least 10 others floating around.
Okay.
So I would be worried about even one case, and certainly two, I would be very concerned. So
I think I think you answered this, but they wanted to know, is plexiglass in front of singers helpful? And
I originally, Steve and I thought that maybe this would be good. After the article from the New York Times, and they actually show what they did is they had singers inhale e-cigarette smoke and then sing. It was unbelievable. Oh, there's no way a plexiglass would do anything. So you're just wasting plexiglass.
Reuters had an article recently that said the current cases are less potent than they were earlier. Do you think that's true in the U.S.?
I don't think so. I think what's happened is people are more conscious. They're using masks and social distancing. And the beauty is it does depend on inoculum size. So back when people didn't know, they were talking to people without masks, they would get a large dose. So they would get very, very ill. Now, if you're wearing a mask, even if someone else is not, you would reduce the number of virions you would pick up. And that would be, you would be less likely to have a severe case. A lot of the most severe cases are in healthcare workers who were dealing with aerosol procedures, such as that case I presented to you.
Great. Well, can you address the confusing information from the WHO this week about asymptomatic?
Yeah, that was a misquote and it was taken out of context. I think everybody agrees. I mean, I've talked to multiple epidemiology. It's 40 to 60% are asymptomatic or pre-symptomatic. That is, they will get symptoms, but when you see them, they don't have it, or when you test them, they don't have it. And the problem is the early part of that infection, the pre-symptomatic period, is when they have the highest number of viral counts, the highest number, and they're most infectious. This is very different than influenza or even SARS-1. There, it was when you were symptomatic, you were most infectious, and there was a very short pre-symptomatic period. And that's why we think the R sub 0 is so high, because of the long period without symptoms when you're highly infectious. And that's why masks make absolute sense. And I'm telling you, every epidemiologist now agrees on that, or a face shield, one or the other.
This is a question around ACE2. So does the affinity for ACE2 increase risk factors for people taking ACE inhibitors?
Actually, it's been shown that ACE2 inhibitors are protective. So keep it up. It actually reduces it by half the risk of a serious infection. Okay. And that was actually, there were some studies on ARDS, not due to COVID-19, that showed that ACE inhibitors actually helped with ARDS.
And I think you answered this, but I want to just clarify again, because I know there's going to be questions. Wearing a mask does not limit the aerosol virus from singers.
No, the aerosol, correct? If you're singing, that won't stop it. Okay. Won't stop it.
How do the rates of death around the world, how do they compare per 1,000 population? We know the U.S. is highest, but do you happen to know?
Well, see, the problem is case fatality rate is the number of deaths divided by the number that have the disease. So if you aren't doing a lot of testing, you have a lower denominator and your case fatality rate looks higher. So, and the United States actually did a very poor job of testing. So we don't know, our denominator is falsely low, making our fatality rate look quite a bit higher. So it all depends on the degree of testing. And then again, it also depends on how good the care is and how available care is. Obviously, if you have less care, you have a higher mortality rate.
Okay. One person asked, how do we prepare for an increase in the number of those infected in the last weeks, just as we're preparing to reopen? Do you have any concern about this increase in cases?
Oh, absolutely. And that's why I think we all must wear masks. We all must stay inside at home when we can, only go out for necessary things if it's part of your work. The workplaces are working hard to do screenings, encouraging masks, distancing. They are putting up there. It makes sense for plexiglass because you talk with droplets that would prevent them from spreading. So, all these other things rather than total shelter in place, which I think we needed to do. We're not up at 3 now. We're not up at 2. We're at 1.2. So I think these other interventions could be incrementally improved to drop us below 1.
Are there any medicines available for treatment?
There's a drug called remdesivir that does have some benefit. It's an antiviral that actually interferes with the RNA replication. It's in limited supply. Probably you need to do it with moderate to modestly severe disease rather than when they're critically ill. The other thing that there's a good study that just came out, it's a small study that's encouraging, that shows that convalescent plasma, such as was used in this patient, you can donate. If you've had the infection, you can go to Life South. They will check on ELISA to see if you've got antibody. If you do, you can donate your plasma. And we have been giving that to the more critically ill, the severely ill patients. And it does show a 4-day shortening of severity, and there is a trend toward reduced mortality. It was a Chinese study, and they were planning 200 control and 200 experimental. The problem is the epidemic dropped down, so they only got 100 and 100. So the numbers are too low to prove statistically the benefit other than shortening the symptomatic period.
Okay. Do plastic face shields only protect the others, or do they protect the person wearing them?
Both. They'll do both.
Okay.
I would say similar to a face mask.
And then one person wanted to make sure, are cloth face masks just as effective?
Yes, as the throwaway. If you've got a 3-ply cloth, often there's usually a pocket you can put a paper towel in there. That is equivalent to a disposable surgical mask, and probably to a face shield.
Okay. One person asked how you would respond. Some people have dismissed the death rates, saying they're overly inflated because of some folks who are included in that. Is there any truth to that?
No, absolutely not. I have been practicing infectious disease for over 35 years. I have never in my career seen more ill patients, severely ill, and seen more deaths than I have at this period in Gainesville, which had a very small rise and a very small number. You talk to any physician that's cared for these patients, and there is no question that the statistic that it's 5 to 35 times more deadly than influenza is correct.
Okay. We've dealt with some of the singing, but one person wanted to know, does humming produce aerosols?
I don't know.
Okay.
Someone else asked that. I can't tell you.
Okay. And then how often should a singer be retested?
Every 2 weeks is the rule of thumb. Yeah, every 2 weeks.
And then around fans, should inside sanctuary fans be on or off during?
No, I would leave them off.
Okay. Would you recommend a small gathering of 20 persons of 70 years or older inside if they were wearing masks and they were socially distant?
It depends on the size of the space.
Okay.
Your routine conference room, I think, attends. I think you've got to plot out. Steve's church, they've actually plotted out distancing 6 feet, and you'll see by the area of the room how many you can, even our largest one maybe can handle 12, 14. So I think it's all in spacing 6 feet. And the good news is I think most of the elderly, if they aren't in a nursing home, have been very cautious, and they're very unlikely to be carrying the disease. And one other thing, we came up with a great idea, I thought it was my idea, is you would cohort those, put those on the left side that are 60 or 65 and older, put the families over in the far right, and those in the middle age in the middle. And that way the families are going to be the highest risk. They're going to have the most asymptomatic, and kids are going to be going back to school. So they would be farthest from the elderly. And then those in the middle would be, their risk factor would be somewhere in the middle.
Okay. Could you make some of your summary slides available?
Sure, I'd be happy to. Definitely.
Okay. Any need to clean cloth upholstery on chairs?
No, it's not worth it. And you're just going to denature all your cloth and cause harm to it. And remember, you leave it for 3 days and it's sterile.
What about hymnals? Should they remove the hymnals?
I think that's debatable. Right now, I know that's recommended. I think it's overkill, but I think that is the recommendation, so probably shouldn't.
Should preachers use shields when they preach?
I think that's not a bad idea, because talking could spread. It depends on the size of the church. For instance, our church, they use microphones. They're going to be 20 feet away. I don't think you need it. If you've got a tight church where it'll be only 6, 8, 10 feet, maybe a plastic shield, because you will use a mic, won't interfere and might be a little bit helpful. So I think it depends on the geographic construction, layout of your church.
Okay. One person asked about handbells and another person asked about wind instruments. Are there any concerns?
I think those are fine.
Okay. Is it safe at this point to exceed 10 persons if they're using masks and social distancing? I heard you say that they could go a little bit beyond 10.
Yeah, in smaller conference room, and then in the larger gatherings, we're going to start with 50, work up to 100, possibly 200.
And then if they have multiple services in the same room, is there any risk with the aerosols remaining in the air between services?
That's why, obviously the audience is not going to sing. So I think, no, I don't think, and it's going to take about 15 minutes to get out and 15 minutes to get in. By that time, and you're opening the doors, you're diluting out. I think it would be okay. And then we had ideas, have for the first service sit in the odd seats, in the second service sit in the even seats, and therefore you would have fresh seats that you would sit in for the second service. So that's another thought. I think that was very clever. And then if you don't have a service for 3 days, everything is naturally decontaminated.
Very helpful. Do you know how Florida might determine its red, yellow, and green zones?
I've been talking to the public health group. I don't know. I think I'm going to encourage them to do that. I think that would be really great. I know I'm friends with a number of people there, and I can talk to them. I think that would be a great idea. It would really, really be helpful. And do it by zip code.
And then is there any reason to require N95 masks?
No. I can think of no. That's really for healthcare providers where there's aerosolized procedures. Dentists are going to certainly need them where they're aerosolizing a lot. But I can't see any reason why, lay people would need N95s.
Oh, another question about singing. Could 2 or 3 singers get together and record songs to be used, or would you prefer them to be in different locations?
Well, it depends. One of the other things that's been talked about is you could declare a group of people who are sort of your close COVID-19 buddies. and you would all practice ultra safe isolation techniques and would trust each other, and in which case you all could interact normally. And that's being done. And certainly families, that's what families have to do. But you could, doesn't have to be a family, you can declare your little family, and that could be a group of singers. And within 14 days, if you've been cautious for 14 days, if you have no symptoms, you will not, it's highly unlikely you will be infectious. So that's the other thing you could do. Everybody could quarantine for 14 days, be really careful, and then you could get together.
Okay. What about cleaning between services? Do they need to clean and sanitize?
We just thought hard surfaces, doorknobs, things that would be a common touch areas, bathrooms, that would be it. I don't think chairs or any of that would be, you don't do anything with those.
And is it safe to collectively speak and say the Lord's Prayer together?
Yes, you're wearing masks. The speaking is good. Those droplets are going to be blocked. That'll be fine.
Okay. One person wanted to know, if they're wearing a mask, why do they also have to be separated by 6 feet?
It's a double, because inside, there may be a little bit of aerosol. There may be smaller droplets. You can go beyond 6 feet with a sneeze. Say, people sneeze all the time. I've sneezed. So if I'm infected, I could get 6 or 7 people. They're not wearing masks. So it's really a way of making sure, mistake proofing further.
What about restrooms during church? Is that okay to have those open? And
yeah, I think so. And people would maintain 6 feet.
Okay.
Wash their hands.
If they're doing a drive-in church and they have their windows open, do they need to wear a mask?
No, I don't think so.
Okay.
You're fine.
What about kids under 10 wearing masks? Children?
The data on children is not really out yet, but so far it does not appear children under 10 spread the infection to others. The Chinese, all the China data suggests that kids in the family were not the person who brought it in. And there's also a study now that shows ACE2 receptors go up as you get older, and they're very low in those under age 10. So, but we don't have viral counts or viral concentrations. We do know they do get infected. We also know they get minimal or no symptoms and almost never get severe disease, except for this very rare inflammatory syndrome, which is probably an immune reaction, an abnormal immune reaction.
So could you, based on that, give some guidance around childcare, preschools, day camps?
Yeah, I think they are relatively safe. I think they can be, you can have them. The one worry is when the child comes back, if there's a grandparent in the house, that's a little bit of a problem. But, and I would have those that are counselors and helping out it'd be nice if they were under 30. And certainly I wouldn't want anybody over 60 to be helping.
One group wants to know, this is our campus ministers, they're wondering what your sense is about colleges and universities opening up in the fall.
I think they probably will. Again, it's the risk-benefit ratio here, the amount of harm. The young people probably, if they get sick, it won't be that severe. The danger is actually to the professors, and there's danger in getting out in the community. And it's going to have to very closely monitored, and we're going to have very aggressive case, contact tracing. And there's actually going to be dorms for quarantining and isolation that are going to have to be activated. That's going to be very much work in progress, but I really think it would be horrible and unfair to destroy the university experience because of this, if we can manage.
One person wondered, are you encouraging the elderly to continue to shelter in place? And if they have a mostly older congregation, should they delay their opening until later in the fall?
Yes, I think that is the wisest course of action. given the severity of complications for that group.
Great. What about UV lights and the air handler? Does that help?
I don't know. I haven't seen UV light will kill the virus, and I don't know how long yet. We're still working on that. You have to be very careful with UV light because it can really damage the eyes, and it can be inadvertently cause eye damage when someone doesn't know it's on. So I'm not a big fan of UV lights, but they are effective.
Do you think clergy should get tested?
If they're going to sing, if they're not going to sing, I'm not sure, because I think that speaking, and you're distancing yourself, and if you use plexiglass, I think you're pretty safe. I would leave that up to the minister and the parishioners.
Can you comment on how far the aerosols travel from an individual singer?
It really varies. It depends on the air. Remember, it's a gas. So if there's a flow of air and the flow is behind that singer, it could travel 100 yards.
Any concerns about aerosol being created through preaching?
I don't think so. Probably not. It'll be fine. Particularly if everybody I think it's important to use a mic. If you really yell, theoretically it might happen. But I think if you talk in a normal voice, it'll just be droplets, and those really drop by 6 feet.
Do you think this information about singing means we might not be able to sing until there's a vaccine?
That, unfortunately, is my conclusion. Yeah.
And would you think we would need to wear masks in worship until a vaccine is found?
Yes. I think all of the things that I've described are not going to change, because remember, they're only right now at maximum 2% of our population is affected. That means 98% of us are susceptible. And that is a formula for rapid spread if we don't continue these procedures. And it's not going to change until there's a vaccine. And that's the only way to get herd immunity. And remember, Sweden they thought they could get herd immunity through natural ways. They have found now they really regret doing that. And their epidemiologist has apologized, because what they've seen of all the Scandinavian countries, they have suffered the highest mortality, and it's still going up. And they have now gone to shelter in place and regret that they did that.
A few more questions, and thank you, Doctor, for your time. We really appreciate it. A few people want to know, would you personally attend church, or would you stay home?
Well, I think it somewhat depends on whether you like the virtual services. And I love our virtual services. So I think Kathy and I are going to stay with virtual. Now, we might come once in a while. And I think I want to see how this all works out and how well people adhere to all these procedures. Remember, these are techniques, these are methods, these are habits that we are going to have to learn. And in the beginning, there will be some slip-ups. And I'd rather not be there when there's a slip-up. And so I probably won't in the beginning, but I may in the future, as we become convinced that everybody is really adhering to all these procedures.
Could you answer a question about, is it possible that the cooler months will increase the cases of the virus? Colder months?
There does not, in the setting of such a high number of cases and the ability of this virus to spread, most experts feel that temperature is not going to help do anything.
Okay.
The reason most of the time that things spread more is because people have to come inside. And in Florida, that's not an issue. In fact, it might be better when it cools down because we can do more outside. And one of the mistakes, I think, when we started shelter in place, everybody was afraid to go outside. What a mistake that was. We should have gone outside. That would have made us feel better. And the outside is very safe as long as you stay 6 feet from others. And you're not in a closed space. You don't go into a public environment. If you stay outside, public outside is safe.
Okay, and then can you talk about communion? What you recommend on communion?
That's a difficult one. I think with masks, and I think just soft talking, and then I still think the if you have gloves, the routine bread and dipping into is fine. But I think everybody wants to have sterile cups, and I think that's in little wrapped bread, and that's probably is the safest. Although I don't think that the other would be a problem, honestly. But probably that's the way. I think certainly the bread, probably this person shouldn't be tearing it because they could contaminate it. So a little piece, packaged bread would probably be best. And then the problem is you can't rip that open during, when you're at the site. So probably you'll have to have a little cup with a little bit of wine. That'll probably be a disposable cup. That probably makes the most sense.
And then some people want to know, is there any wisdom on people entering in one direction, exiting another? How do they handle closed hallways?
Very good idea. Yes,
okay.
You want one direction. You don't want anybody going face to face if you can possibly help it.
Youth, middle school events?
Middle school events are okay without a lot of older adults there. Yeah, I think the camp, the camps and those kinds of things are fine. So yeah, I think middle school is fine.
And what about smaller home gatherings? Are those better than larger congregational gatherings?
Well, it depends on the size of the home and the ceilings. So I think it's probably better to gather in large conference rooms that are well defined than homes. Now, if someone has a giant tall ceiling room, those are pretty safe. So then you could meet in that house. Yeah.
Okay.
A low ceiling house with low ventilation might be a risk.
Is there any online resource for the fever map?
Yes. Yeah. Just Kinsa weather map.
Okay.
Just Google that. Kinsa weather map.
And what about people with asthma? Are they still at a higher risk?
It's interesting. This virus doesn't seem to precipitate wheezing. And it turns out that we thought asthma would be a big problem, but it is not. It's not been. So I don't think it's as great a risk as we originally thought. The one area that we've really seen a problem is obesity. Younger people with the high BMI over 34 really, really do badly. And they end up on respirators much earlier than others because the weight of their stomach lifts the diaphragm up, and their respiratory reserve is very, very low. And so when those alveoli fill with fluid, they have a great difficulty compensating, and it's really, really bad.
Another medical related question, are people with an underlying clotting issue, such as, I'm not going to say this probably right, antiphospholipid antibody syndrome, are they at a higher risk?
It's not real clear. I can tell you I didn't get into that, but we're seeing that in serious cases that this virus does damage the vessel walls, and then the vessel walls, which usually can protect against clotting, actually clot. And we're seeing a lot of clotting in patients that end up in the ICU very sick. About 1/3 of them have abnormal thrombosis, either thrombophlebitis to their legs or a clot to their lungs, a pulmonary embolus. And there's now we're using blood thinners when there's a thing called a D-dimer that seems to associate with clot burden. And we are using anticoagulants. Now, someone who has antiphospholipid should be on anticoagulants already. So in a way, they'll be protected.
Okay. And then what about church-wide meals, even outside?
I think they need to be individually served. I don't think buffets are a good idea.
Okay. All right, we're getting close to the end. I'm confident. Some folks want to know how you would determine the red, yellow, green zones for Florida. I think you said you were going to check on that.
Yeah, we have to check on it. You have to know the number of cases per 100,000 in your area. It's all about the number of cases that have been identified in your area. That's the key to this.
And then how long is the pre-symptomatic period?
Usually 2 to 3 days, and then mild symptoms for 2 days. And that is those first about 5 days, 5 to 6 days is when most of the people transmit to other people. That is the most infectious time. See, that's the problem. By the time you get really bad symptoms, you seek medical attention, you're usually not that infectious anymore.
Okay. So he did clarify that gatherings are okay for middle schoolers, but masks and social distancing, and recommending smaller groups. I think you did say when we wear a mask, it doesn't matter necessarily what kind, but it needs to cover our nose and our mouth.
Nose and under the chin, yes.
Okay. And we will try to share some of this mask video. Children's Sunday school is okay, but limited and using the guidelines. So I think one person wanted to know, are you concerned about these outside protests and any spread from that?
Oh, yes, because they were yelling and they were having their masks off when they're yelling, and they were much closer than 6 feet. So I think that I don't know how much it's outside, but this is a very bad outside conditions. So there's every likelihood there will be an outbreak from this. Yeah, unfortunately.
Okay. You did
and
say
it'll
that
show up 2 weeks from the end of the protests.
Okay. And you did say if someone has tested for the antibodies, then if they did gave platelets, that would be helpful, correct?
Yes, or plasma.
Okay.
Yes.
Thank you.
Yes, that is helpful. That would be helpful. I think everybody's now realizing, and there's over 100 years of experience with convalescent plasma on many, many other diseases. And it was shown to be a benefit in all of them. And the toxicity is exceedingly low.
And then one last question, and then I'll address two that are more to the conference. Do you think they should keep a record of who comes to the service, where they sit, in order to track potentially if there is an outbreak?
That would be helpful.
Okay.
That would be helpful.
All right. Well, Dr. Southwick, I cannot even begin to say how grateful we are. We will make this recording available, and if you'll send me your slides, and we know there may be some that you can't share, but any that you can. I do want to address two questions that were asked, and we have people applauding on the comments, so everyone is very, very grateful.
Good. Well, thank you. Thank you.
Yeah, and there's other comments people can see that have great suggestions. But one question that someone said is, can we use this information in our guidelines, even though it does not agree with the current conference guidelines? I would say to you that essentially we have tried to make our conference guidelines very similar to what Dr. Southwick has.
I think they're very similar. I don't see any, they weren't maybe not quite as detailed. And I think every church is going to, the principles now.
Yeah.
So follow those principles. That's why you need to know how it's spread.
Exactly.
And that's how you decide.
Yeah, and I would say that I want to be clear with everyone in the group. We did not recommend you return to in-person worship after June 15th. We actually recommended outside or drive-in worship, but we are allowing for in-person worship if you meet all the guidelines. And we would add to those guidelines now testing any singers who are soloists, as well as some of the other things that you have mentioned. And so we'll do that. But if you have a specific question around our guidelines, let us know. The last question, and I'll finish with this, is someone said, how do you respond to those who say, I have faith, I'm not worried? And I would just say to you that our faith is multidimensional. That part of our faith is to love our neighbors. And so as Dr. Southwick said, we care for one another by showing that we will wear a mask, and that our faith is not just our faith in us not getting sick, but our faith is an active faith that says we are out to love our neighbors and to protect the most vulnerable and to make sure that we're doing all we can to reduce the spread of this virus. That is a very important and essential part of our faith. So again, thank you so much for joining us. We pray God's peace upon you. And Dr. Southwick, we are just very, very grateful for your time, and Steve and Catherine for your connection with us. Blessings to all of you, and please let us know how we can continue to help